Kobe, yes, I'll record it. It's being recorded. So it's pretty common. That's the idea. No particular age delineation. You can get this as a child and get this as an elderly person and get it throughout life. Women have it more than men, maybe. This is actually some stuff coming out on this that men may have depression more than they seem to because they present not with depressed mood, but with irritability. Just everything's kind of irritable. They're kind of angry all the time. So it may not be that much of a difference. And of course, men complete suicide more often than women, about 4 times as often. And women attempt it more than men. But so there's
what are the like cultural like norms of it, like how it's like men don't show emotion, this and that kind of also factor into that?
That's probably some of it. Yeah, it is. That the way men modulate their emotions is going to be different, and they're not supposed to have them. Yeah, not supposed to show that they're hurt. Yep, absolutely. There's various types of major depression. There's single episodes and recurrent. Apparently, about 50% of people who have a depressive episode will just have one. There's studies that will imply that, but a lot of people will have recurring. If you have 2, the chances of you having 3 are increased, and if you have 3, it's likely that you're going to have recurring major depression. So here's the symptoms of depression: the depressed mood. Anhedonia means no pleasure. Hedonism is a philosophy that you should seek as much pleasure as you possibly can, and an is none. Like anhydrous, there's no water, so anhedonia. Sleep disturbance and appetite disturbance, either too much or too little of both. With sleep disturbance, there's a thing called early morning awakening, where they wake up at like 2 in the morning and then can't go back to sleep. And people eat too much or just not eat at all. Again, agitation or retardation, people just seem leaden. They just don't hardly move at all, or they just can hardly not move because they're just agitated. Then loss of energy. I'm making sure I keep up with all this stuff again. Loss of energy, loss of feeling worthless, feeling inappropriate guilt, to feel guilty about everything, can't concentrate, think about death. And thinking about death is a bit different than suicidal ideation. Okay, the suicidal ideation is that I'm trying to, thinking about suicide per se. And then they have other symptoms that aren't criteria necessarily, but they are symptoms that go along with it. People just feel miserable and humiliated. Nothing's funny. Everything's just like, yeah, whatever. It's just not funny. Probably falls under the anhedonia aspect of depression, but you can see this per se. Lack of spontaneity, not really wanting intimacy, and just not care about anything, and just nothing matters. Just nothing matters. More time alone. They just move more slowly. So inadequate, undesirable, blame self. All these are part of the cognitive aspects of depression. Excuse me. And pain, headaches, pain, and indigestion. They have a lot of physical symptoms that go along with this. There's quite a few specifiers: anxious, distressed, mixed features, melancholic. Melancholy, let's see, I'll get to the actual, what that looks like here. Melancholy is just, I think it's coming up here. There we are. It's the next one. Atypical, what that means is they eat more and sleep more. That's generally atypical. It's usually the other way around. Mood congruent psychotic features and mood incongruent. So mood congruent might be something that they're depressed and they think they're dying of cancer. They're filled with cancer, which is depressing. Or they might be depressed but also think they're the next coming of a savior. Catatonia is just they're so much not moving that they seem catatonic. Peripartum onset that occurs around delivery, either just before or just after. And then seasonal pattern. There used to be the seasonal affective disorder. That used to be its own thing. It's not now. In the DSM-5, it wasn't in the DSM-3 and 4, but it's not in the DSM-5 for the same reason that Asperger's isn't, because nobody really agreed upon what was seasonal affective disorder versus not. So it's just, now it has a seasonal pattern. They're more depressed in the winter. Did I hear a question? Nope. Okay. So here's the features of melancholy. There's a severe lack of pleasure, distinct quality of depressed mood. It's just horribly depressed. Very much worse in the morning. They have the early morning awakening. Very much retardation, by the way, and huge guilt, huge weight loss. So it's just kind of a very severe presentation of major depression. And here's some of the atypical ones: hypersomnia, mood reactivity. Mood reactivity, what that means is you think and set it off. They'll see everything as a sort of a personal slight. So that's the mood reactivity. And then the anxious, where they're just very anxious distress. By the way, this part of all these things now, depression, etc. It's kind of nice to have that. That's another thing that the DSM-5 did. It added this anxious distress. The reason it's kind of a good thing is you don't have to make an anxiety diagnosis now. You just have someone just, oh my God, anxiously distressed. And that's what you don't have to make a new diagnosis. They tend to have longer duration, and they don't do as well with this anxious distress. So it's worth differentiating grief from depression, because this sometimes can be, well, confusing. People who have a loss, they feel empty and a loss. They'll have dysphoria. Okay, they'll be sad, but it comes in waves. Okay, that's a kind of a key thing, is that it comes in waves. And if you ever lost a loved one, a parent, or anything of that sort, you know this. It comes in waves. It just suddenly, wow, I miss my mom. Wow, I feel sad about this. And that's it goes away after a time. But yeah, it just comes in waves. Can have positive emotions. They can feel good about other things. It's very sad about this loss. And you think about the deceased a lot, and there's a preserved self-esteem. You're okay. You may have guilt over failing toward the deceased. You didn't quite do enough for them, but again, that's it's not guilt that's all over the place. It's guilt toward this one person, as opposed to excuse me, major depression, where you do have decreased mood. The self-esteem goes away. Pervasive unhappiness, doesn't just come in waves. Very self-loathing, feeling worthless, suicidal ideation, and very self-critical. Again, they have preserved self-esteem, not so much here. So it's worth differentiating those. Yeah, there's a question of how long should grief go on until it's a pathological grief? Well, that's really quite excuse me, it's quite the issue. It's hard to say, but I think most people would agree that if you start having long-term grief and you start getting these symptoms, then you can start saying, well, this is prolonged grief, and they're making criteria for major depression. Here's some other so-called vegetative symptoms. It's sort of an interesting term, vegetative. Very decreased appetite, initial, middle, and terminal. So they worry and ruminate, and they can't sleep because they're worried and ruminating. Very much psychomotor retardation, so they're not hardly moving at all. Very loss of confidence in self, tired, worthless, all these things they feel toward themselves. So major depression is really, it's one of the most disabling illnesses worldwide. When you look at years of production lost, those sort of measures, depression is among the worst. And worse in the morning, moods worse in the morning often. Impotence or anorgasmia, so sexual function is impaired by this as well. And this so-called masked depression, that they don't report a depressed mood. I'd be interested to know. I have to sort of look that up, actually. I don't have my PubMed handy. I'd have to get off teams to do PubMed. But I think men probably have this more often than women, that they just don't report a depressed mood. They may not even know quite what a depressed mood is in a way. They just feel irritated, and everything just pisses them off all the time. Nothing is really very fun. So suicide is going to be a later lecture, obviously. They can begin suddenly or gradually. Sometimes they spontaneously disappear in 6 months, and then other times they're chronic. And there's all kinds of problems with this as far as biological aspects. So genetic, of course. Be careful one thing I've noticed with some of the with Jacob, and this happens every semester, that when we talk about the biological aspects, people will focus on the genetics, and that's true. It's part of it, but it's just part of it. Okay, 50% with identical twins again, so 50-50. It's not just genetic. Serotonin transporters, that's where the transporter brings serotonin back up into the neuron. So those can be abnormal. Do people get a picture of what that looks like when I say transporter brings the serotonin back up into the axon? Because it should. Okay, if you're not getting a visual image of that, like you are with the white bear right now, I need to explain that more. Okay, come back here. Yeah, so here's the axon. Little neuron back there. Yeah, no worries, Amber. It's no worries. Well, dendrites. I don't do it as well here. And here's the dendrite on the other side. Little pyramidal cell and receptor. Let's go to purple. So a little serotonin kind of going out there, attaching to the receptor. Then it gets brought back up into the neuron. This by this transporter gene. It's transported into the axon. That's the idea. And it's not transport like in Star Trek, which is too bad. It's always confused me. So now with serotonin reuptake inhibitors, they block that, right? Like Prozac, Paxil, etc. They block that reuptake and therefore get more serotonin out in the synapse. And that correlates with response to depression. So that's the idea. That's the serotonin transport abnormalities. And so when I say serotonin transporter abnormalities, it has problematic pathological reuptake into the axonal terminal. You should get this very sloppy picture in your mind from here on out. And it wouldn't be one of my lectures without my swooshes. So same sort of idea here. Again, the Raphe nucleus and really it's the locus coeruleus. Locus coeruleus is a noradrenergic one. Again, it has a swoosh through the cingulate gyrus, and then all these branches. And these are all really long axons. I think that's one of the things that I may not emphasize enough because I sort of reflect on how I'm talking about these things. So yeah, this is the cell bodies are here. That's the nucleus. The cell bodies are there. And they have, someone's not unmuted, but it's okay. I think we're about done here today anyway. And then it goes around and then it has the branches of the axon. So it's good to keep that in mind when you're thinking about treatment with the medications, that kind of get again, a visual imagery of where these things are in the brain and how they're attaching to stuff. That's the point of these images. Serotonin, of course, same sort of idea. Raphe nucleus, this is all in the midbrain. All right, so here's the pons, medulla, cerebellum back here. This is the midbrain. This is the thalamus. There's a nice little pituitary, right? Nice little pituitary down from the hypothalamus, and then boom, off they go. And 4 dopamine pathways. Can't hardly do a talk without talking about the 4 dopamine pathways. So there's the nigrostriatal, basal ganglia and stria on through here. So that's with motion. That's when you block that, you get the EPS, you get all the symptoms, and tardive dyskinesia comes through that as well. Prolactin levels, keep them down, right? So with prolactin, dopamine blocks prolactin release. You block dopamine, you block the blocker, and up you go with prolactin. And the serotonin, the 5-HT, serotonin is 5-hydroxytryptophan. It's also, so it's 5-HT. When they talk about 5-HT on those depines, the drones, 2 pips and a rip, they're talking about serotonin. So when you're blocking that one along with dopamine, the effect is much better. All the negative symptoms are improved as well. All right, well, let's ties it up here. So let's stop there, okay, because that's 15 minutes. That's a good place to stop. And get out of this. Really can't emphasize those pathways enough. No, you really can't. You really can't.